Hi, my name's Sam Anderson, and my project is on heparin monitoring and dosing using the aPTT versus the anti-factor Xa assay. Okay, firstly, I want to talk about heparin. Heparin is an anticoagulant and is commonly used in hospitals for the prevention and treatment of thromboembolic disorders such as deep vein thrombosis, pulmonary embolism, and acute coronary syndrome. It acts by inhibiting clotting factors thrombin and factor Xa. The therapeutic effectiveness of heparin is closely monitored to prevent both underdosing and overdosing. Historically, activated partial thromboplastin time, or aPTT, has been used to monitor heparin therapy. However, recent evidence suggests that the anti-factor Xa or anti-Xa assay could be a more reliable method for ensuring optimal heparin levels. The purpose of this research project is to explore the efficacy of these two monitoring methods and their implications for hospital practices, focusing on research findings and their potential impact on patient care. When it comes to current practices in the hospital setting, most hospitals do use aPTT as the primary method for monitoring heparin therapy. This was the case at the hospital that I used to work at in Columbus, Ohio. The aPTT measures the time it takes for blood to clot and is used to determine the level of anticoagulation based on that value that's given. This is a more indirect method of monitoring heparin efficacy, and as a result, it does have some limitations. It can be influenced by various factors such as the patient's baseline clotting ability, presence of a lupus anticoagulant, or hematocrit levels. Additionally, different hospital laboratories may have variations in their aPTT ranges due to differences in reagents, which can lead to inconsistent results at times. At the hospital level, nurses and healthcare providers rely on aPTT values to titrate heparin drips, adjusting the infusion rate to reach therapeutic range. This approach, while widely used, may not always result in optimal anticoagulation levels and can contribute to suboptimal patient outcomes. I can actually corroborate this with my own experience. The hospital I used to work at, we would do heparin drips fairly frequently, and it did feel like it would take a long time to get the heparin drip to a therapeutic level. It felt like we were chasing it with multiple titrations during our shift. And it also felt like it could just as easily become untherapeutic as soon as we got it therapeutic, even if we were doing everything right. The Anti-Xa assay, which I will go into more detail about on the next slide, has a more direct method of measuring heparin concentration. The Anti-Xa assay measures the degree to which factor Xa is being inhibited. This provides a way to measure how much heparin is in the patient's blood, and again, it is a more direct method of measurement than the aPTT. Okay, moving on to research evidence when it comes to the Anti-Xa assay. Recent studies do suggest that Anti-Xa monitoring could offer a more accurate and reliable method for managing heparin therapy. Unlike aPTT, the Anti-Xa assay measures the degree to which heparin is inhibiting factor Xa in the blood, providing a more precise assessment of therapeutic levels. Research has shown that Anti-Xa assay correlates better with clinical outcomes and offers less variability between patients, making it a potentially superior option for ensuring consistent anticoagulation. So in one study I found published in the Journal of Thrombosis and Hemostasis in 2020, researchers found that Anti-Xa levels were more predictive of bleeding and thromboembolic events than aPTT. The study indicated that hospitals using Anti-Xa monitoring experienced fewer adverse events and more consistent therapeutic outcomes. Another study conducted by Circulation in 2019 demonstrated that the Anti-Xa assay provided better patient safety by allowing for more precise dosing and quicker adjustments to heparin infusions. In regards to barriers to the Anti-Xa assay implementation, while the research that I presented does support the use of Anti-Xa assay, implementation at the hospital level remains inconsistent. The cost and availability of Anti-Xa assay can be a barrier to widespread adoption, and healthcare providers may be unfamiliar with the new monitoring technique, necessitating training and education. However, given the promising evidence of better clinical outcomes, transitioning to Anti-Xa monitoring could be a valuable investment in improving patient care. Now, obviously, Ivanson already uses the Anti-Xa, so I don't have to convince you to implement it, but it is worth diving a little bit deeper into and understanding it a little bit more, especially versus the aPTT. And there are some instances where the Anti-Xa is actually not the best form of heparin monitoring to use, which I'll go more into in the next slide. Okay, like I just mentioned, the Anti-Xa assay is not always the best option for heparin dosing and does have some limitations. In the article Anti-Factor Xa Monitoring for Unfractioned Heparin Therapy in 2017, it explains that interference to the Anti-Xa assay can occur as a result of patients who take direct oral anticoagulants, or DOACs, such as apixaban, which we commonly use at Ivanson on the med-surg floor. This happens because DOAC medications are designed to inhibit factor Xa processes and will result in falsely elevated anti-Xa levels. So in the instance of a patient who has chronically taken a type of DOAC and now requires intravenous heparin dosing, it might be a better idea to use aPTT for heparin monitoring in order to avoid underdosing. The key takeaway from this research project is that adopting the Anti-Xa assay for heparin monitoring could lead to more precise dosing and improved clinical outcomes. Hospitals currently using aPTT as the sole monitoring method should consider including the use of Anti-Xa assay, especially in high-risk patient populations or those who exhibit unpredictable responses to heparin. The change in practice could also contribute to better standardization of anticoagulation therapy, leading to fewer adverse events and a reduction in prolonged hospital stays due to complications. However, the use of aPTT should not be completely abandoned for the previously stated limitations to the Anti-Xa assay. Lastly, I just want to reiterate some of the positives that the Anti-Xa assay brings to heparin monitoring and dosing. It does expedite the therapeutic dosing of heparin, meaning that you're able to get to a therapeutic dosing of heparin a lot faster than if you were using the aPTT to monitor your heparin levels. It does provide a higher degree of patient safety, and you have fewer adverse events and complications, again, because you're getting to a therapeutic dose faster and more accurately. And again, it does promote more positive patient outcomes. To wrap it all up, these are my references, and thank you guys for listening to my presentation.